over the seizure information. There's a section in IGGI. Don't worry too much about reading the other articles that you have here. If you want to do that, you can access these articles through the library database. You need to know how to go through the library database to get to articles anyway. You'll definitely need it when you write a research paper for Dr. Dover. And you can get all the mainstream nursing journals, you know, nursing, American Journal of Nursing, through the database. But there's plenty in your chapter, isn't there? So if you read chapter 71 in IGGI, the whole chapter is, now see, I'm going to have to change the name up here sooner or later, because I still think about it as acute renal failure and chronic renal failure. But the American Kidney Foundation doesn't like us to continue to use the word renal because the public doesn't really understand that it's the same word as kidney. So they're trying to make it more public education. And so now, chronic renal failure is chronic kidney disease. So instead of being CRF, it's CKD. Chronic kidney disease, same thing. And your chapter in IGGI, this latest edition, calls it that. They don't use the word renal in there either. They talk about acute kidney injury, which is acute renal failure. And they talk about chronic kidney disease, which is chronic renal failure. So those of us who've been using the word renal for a long time have to start using the word kidney instead. And part of it is about public education. Because chronic kidney disease is a huge public health problem, especially in some communities. So where do you think the highest incidence of chronic kidney disease is in this country? Well, it is African American communities. So when I say where, not so much who, but where, it is in places like Washington, D.C. and Baltimore. Washington, D.C. and Baltimore City have extremely high incidence of chronic kidney disease. So that's why it's an important public health issue, and that's especially if you are from or plan to address public health needs in the African and African American communities, and other communities as well. You need to really advocate for screening, healthy lifestyles, and management of kidney disease before it becomes end-stage chronic kidney disease. Because once somebody's in end-stage chronic kidney disease, then they have to either be on what? Dialysis or get a transplant. Okay? So we're going to talk about that.
I'm taking care of a patient
On dialysis?
where he's about to stop, he just put in a graft.
They just put in an AV graft or arteriovenous graft so they can access it to have dialysis. So the lifeline for a patient on dialysis is their vascular access. If they have hemodialysis, which is the most common form of dialysis. So you guys are kind of fortunate. You have your lab, you know, either right after class today or tomorrow morning, and we're going to talk in lab this week about dialysis. And I'll show you peritoneal dialysis, and we'll also talk a little bit about hemodialysis. So what are the most common causes of chronic kidney disease or chronic renal failure? Hypertension and diabetes. Some people with diabetes have both. Okay, so diabetes type 1 or 2, although 90% of diabetics have type 2, or hypertension, uncontrolled hypertension. That's why we call hypertension the silent killer, because people can walk around with untreated hypertension for years, and meanwhile their kidneys are slowly failing. Okay, so it's really important. Some of you, next semester, you're supposed to do service hours for Dr. Dover's class, and a couple of people, I think it was last year, the National Kidney Foundation came here with a group called MIKE, which stands for Minority Intervention for Kidney Education. And they set up kidney screening in Largo Student Center. So what types of things do you think the students did in that MIKE screening?
Blood
pressure.
Glucose level.
Glucose levels. They actually did urinalysis. They had a little thing they could run. And if they had protein or, things, high levels of glucose or something abnormal in their urine, so then they were set up to refer. Because if you're going to screen people and tell them that they're at risk or they have something abnormal, you have to have somewhere where they can go to address that risk. So it was blood pressure, glucose. They drew blood for something else too. I think they might have even run it for creatinine, which of course is a direct measure of glomerular filtration. And they did, that's what they did. And they did the urinalysis. Okay, so let's talk about renal failure. The first couple slides here are just review of A&P. which you've had. And of course, you need to know normal A&P before you can understand the patho, right? The pathophysiology. So we know the urinary tract includes the kidneys. And anywhere in that system, your kidneys manage fluid balance, right? Along with hormones and other parts of the endocrine system, electrolyte and acid-base balance. So we'll talk again in 2032 about blood gases. So if you have a respiratory problem, you may have metabolic compensation. If you have a metabolic problem and your acid-base balance is off, you might have respiratory compensation. So we'll talk about that too. If you have diabetic ketoacidosis, which is a hyperglycemic emergency in type 1 diabetics, or you have chronic renal failure, chronic kidney disease, and you develop metabolic acidosis, you can develop a respiratory pattern called Kussmaul's respirations to try to blow off the excess hydrogen ions. Okay, so here's just a picture of the anatomy. You have the kidneys, two kidneys, 2 ureters, 1 bladder, 1 urethra, and men have a prostate. Women don't, but elderly men can get enlarged prostates, even if it's benign prostatic hypertrophy, that can affect urine flow, and all of that works together. So again, if somebody has costovertebral angle tenderness, you see the acronym CVA tenderness, they're not talking about a stroke. CVA tenderness means that they're tender where? Where's your costovertebral angle? Right here. So what's under your costovertebral angle? Your kidneys. So if you have CVA tenderness, it may be related to a kidney infection. That's one of the things you can assess in looking at somebody with a UTI. Hopefully the UTI is still in their bladder and it's cystitis. But if it goes up, if they have reflux of urine or the infection ascends into the kidneys, they can develop a kidney infection. And then they could even get urosepsis, couldn't they? Okay, so we know that the kidneys are also very sensitive to blood flow. 20% of the blood pumped by the heart goes through the kidneys because it's the blood that goes through the kidneys, and then at the level of the glomerulus, the fluid and waste is excreted. Okay, so then this is all review of the A&P, and they have a little bit of that and some better pictures in your chapter 71. Okay. So my point is that you can have problems with the kidney or you can have problems with the rest of the system that can become a problem with the kidney if it backs up. And then the glomerulus, we have the nephrons, which is the working unit of the kidney, about 1 million in each kidney. So the other point here is if somebody has slowly developing chronic kidney disease from, say, diabetes or hypertension, they can go a long time. They can develop renal insufficiency. It may take months or years of whatever that causes that's doing the kidneys in before they actually develop chronic kidney disease to the point where they need dialysis. Whereas acute kidney injury usually happens quickly. Anybody know what the most common cause of acute kidney disease is, or kidney injury? It's decreased renal perfusion, the bottom bullet there. If somebody is hypovolemic, or they're in any kind of shock, which it means they have what? Low blood pressure, and they don't get good renal perfusion, then they're going to have decreased urine output, right? And if the blood flow to the kidney is decreased long enough, they can have acute kidney injury or acute renal failure. So there's a lot of things that can cause shock and decrease kidney perfusion. I mentioned one. One is hypovolemic. What are some causes of hypovolemia? Trauma, hemorrhage, loss of blood, dehydration, loss of fluid volume. Okay, good. Cardiogenic, somebody who has decreased cardiac function and their muscle doesn't pump, the heart doesn't pump. That'll decrease their kidney perfusion because their blood pressure is too low. That's the most common cause of acute kidney injury. All right, but most patients that we work with have chronic kidney disease, don't they? So this is the things that the kidney does. Takes away waste, reabsorbs necessary chemicals, sodium, potassium, also fluid. All right, now let's look at, I have this magic chart in your study guide. It's on page 63. So everybody get this. Page 63 in your study guide. Okay? Everything you need to know except the nursing interventions is on this chart. Call it a concept map or whatever you want to call it. I mean, they have other things called that in the IGGI chapter. And the whole chapter on chapter 71 is on renal failure. But this chart here has it all. It says renal failure diagram. Renal failure diagram. So we're going to talk about kidney functions, which if you look across the middle, well, first of all, in the very center, because it is sort of a concept map, is supposed to be your patient with renal failure, or kidney disease, if you will, and loss of kidney function. To the left of that patient in the center, it says acute. Acute kidney injury, acute renal failure, I don't care what we call it, same thing. What are some characteristics of acute renal failure? It says it's reversible, and the patient can have oliguria initially, which is decreased urine output. And then as the kidneys recover, because they recover in acute renal failure, they will have a diuresis phase. Now, let me just say this right now. There's a whole bunch of stuff in IGGI. All you really need to know about acute kidney injury, or acute renal failure, which I still think sounds better, is that they're going to have a sudden decrease in kidney function. Usually it's from hypoperfusion, decreased blood flow. And they're going to have decreased urine output because of the decreased perfusion. So how would we treat it? First of all, to see if the patient has reversible kidney disease, because if we do this, the urine output will pick up, or to treat hypoperfusion, especially if it's hypovolemia. Look to the left of that. It should be or, not of. Patient would get a fluid challenge. What do we mean by a fluid challenge? To the left of where it says acute. It says fluid of. Let's just say fluid or diuretic challenge. What do we mean by a fluid challenge? The doc orders, patient comes in, they're in trauma, they're hypovolemic, they're shocky. We want their urine output is down. We're going to give them a bolus of fluid. IV normal saline, for example. They'll say bolus them with 500 mils of saline. What's that mean to you?
Open it up.
That means you're going to hang an IV of normal saline, you're going to open it up and give them 500 mils. That may be over 30 minutes. Maybe they say over 30 minutes. 500 mils over 30 minutes of normal saline. Isotonic, 0.9% normal saline. So that would be a fluid challenge, right? And if the blood pressure comes up, the renal perfusion comes up, and the kidneys have reversible disease, they'll pee more. If the patient has chronic kidney disease, you can give them anything, they won't pee. Somebody that doesn't make urine we call anuric. People with end-stage chronic renal failure may not even make urine. So you're not going to give them fluid in Lasix, are you? What will the Lasix do? Nothing. But if it's acute and you give them a fluid balance, a fluid challenge, and you maybe add some Lasix or some other kind of rapidly acting diuretic, what kind of diuretic is furosemide? It's a loop diuretic, right? Okay, it's a loop diuretic. There's another one called Bumex, which is in the same category. So if you give them furosemide or epichrinic acid, they should start putting out more urine as their perfusion improves. That's all I want to say about, so you don't need to memorize the stages of acute renal failure. Makes sense that initially they would have decreased urine output, make less pee. That's called, the oliguric phase. If you can turn it around and the kidneys get better, then over time they'll make more urine, they'll diurese, and the patient can recover. It may take a while for acute kidney injury to recover. It may be a period of months even before they fully regain their kidney function. But that's what acute kidney injury or acute renal failure is, okay?
So
All right.
in the book it says this rifle acronym. You don't need to know.
No, you don't need to know the rifle acronym. I'm not going to ask you to do that amount of medical stuff. I want you to know what the nursing assessment and the nursing actions and the nursing interventions are. Okay. But we are going to look at this. So let's look at kidney function. Across the middle, under where it says renal failure, and to the left it says acute, to the right it says chronic, which is slower and irreversible. It says excretory, regulatory, and endocrine. These are the three major functions of the kidney. Again, this should be reviewed, but I love this little chart. Because under regulatory, which is actually in the middle on your chart, it says that the kidneys control fluid, electrolyte, and acid-base balance through glomerular filtration, tubular reabsorption, and tubular secretion. So under it says electrolytes, fluid, and acid-base. If you look to the left, it says if somebody is in renal failure, their kidneys don't work, and we're talking mostly about chronic kidney disease because that's who most of our patients are, they're going to have increased acids, and they can develop acidosis. Is it metabolic or respiratory? Metabolic, of course. So if you look under there where there's bullets, in metabolic acidosis, what happens to the pH? Acidosis means it's down, right? Below 7.35. The bicarb would be down. Okay, good. And then with the metabolic acidosis, they can get CNS depression, decreased level of consciousness, irritability, and they can develop Kussmaul's respirations. Because the Kussmaul's respirations is a respiratory pattern that's rapid and deep and blows off. It's a respiratory compensation for the metabolic acidosis. Because if you have metabolic problems, the respiratory system compensates. If you have respiratory problems, the kidneys compensate. Okay. And there's also excretory. They're connected. To the right, regulatory, it says decreased calcium and decreased vitamin D. So people with the electrolyte that's down in renal failure is calcium. And it's to the right of here. Right there. To the right. Decreased Ca. Ca is calcium. So if somebody has hypocalcemia, it can affect their clotting. It's part of the clotting cascade. They can develop fractures. That's what the FX means. And they can get something called tetany, hypocalcemic tetany. If your calcium gets really low, what's tetany look like? Muscle twitching. That's where you get into carpopedal spasms, Schwastek sign, which is the cheek, Trousseau sign, which is carpopedal spasm if you put the blood pressure cuff on. Okay, so we want to make sure the patient gets calcium supplements. And also vitamin D, because vitamin D is necessary for calcium absorption, right? All right, now look at the bottom here under regulatory. If the waste products are building up, you're going to have decreased levels of what? The first one is Na, that's sodium. And so increased hypernatremia could cause what happens to the blood pressure in these patients? Increase, which further affects the edema, which further elevates the blood pressure. Okay, and then they could feel thirsty. Don't worry about that right now. It might be on fluid restriction. Okay, and then the next one is K. What's K? Okay, so these people have, tell me the medical word, hyperkalemia. Hyperkalemia. What's important, what's a dangerous problem with hyperkalemia? Cardiac dysrhythmias. It can affect muscles, including the heart muscle. They can get some possibly dangerous dysrhythmias. Muscle cramping and weakness. What's a normal potassium level? 3.5 to 5. I've seen patients with 6. Anybody know how we treat severe hyperkalemia? Kayexalate is one way. That's a phosphate binder. It's an ion resin. But these days for quick effect, which Kayexalate isn't, although we still use it, they can give insulin and D50. And insulin is used a lot now. Insulin will drop the potassium. It also drops the blood sugar. So you have to give the D50 to rescue the hypoglycemia caused by the insulin. But you give insulin, it pushes the potassium back into the cells, and the serum potassium drops. So that's one of the emergency treatments now you'll see, is insulin. Okay. Increased PO4. What's PO4? Phosphate. The itching that you see in patients with chronic kidney disease, chronic renal failure, is from the hyperphosphatemia, and it can cause joint pain. Now, in your reading, it gives you a little chart on the inverse relationship between phosphate and calcium. The phosphate is up, the calcium is down. Anybody know some medications we give for high phosphate in renal patients? Sometimes you can tell a patient's a renal patient by looking at their MAR, their med record. Phosphate binders, like what? There's one called Foslo. Ah, Foslo, what's it do? Lower your phosphorus. Foslo is, is a phosphate binder. Renagel, renal, Renagel, Foslo, those decrease phosphorus in patients with hyperphosphatemia, and usually those patients are renal failure, aren't they? Okay. Also retention of fluids. If people aren't peeing out their fluids, they're going to get edema. Don't worry about the loss of fluids right now. That really goes more with the acute renal failure. We kind of talked about that. But the typical chronic kidney disease patient will have increased fluids, which further increases their blood pressure, right? You'll see patients with renal failure with very high blood pressures. One of the main things that helps that is dialysis, where they pull off fluid. The other thing would be antihypertensive medications, which you don't want to give right before they go to dialysis for two reasons. One reason is they'll be dialyzed out, and the other reason is it could drop their blood pressure dangerously low, because what's the most complication during hemodialysis? Hypotension. They're pulling off fluids, and the patient's blood pressure can get really low. They see that quite a bit in hemodialysis. Okay. So that's the regulatory function of the kidney. Now look to the left, where it says excretory, maintains body fluid volume and composition, and filters and excretes waste products from the blood, right? So under excretory, what are some things that are normally excreted that are going to build up in renal failure? Protein metabolism end products. So the protein metabolism end product that builds up is urea. Urea, and that's what's urea? What's the acronym? BUN. Stands for blood urea nitrogen. And then creatinine, it should say creatinine, not creatine. Creatinine is very sensitive to glomerular filtration, and people who have renal failure have elevated creatinine above normal. BUN will go up also. Sometimes people with dehydration can have a high BUN, and when you hydrate them, the BUN comes down. But creatinine is a pretty sensitive measure of kidney function, isn't it? Serum creatinine and serum urea nitrogen. So if somebody has these protein waste products that's built up, you can see the bullets underneath. Somebody with a very high BUN and creatinine can have level of consciousness changes, drowsiness, confusion, anorexia, nausea and vomiting, GI ulceration, muscle twitching. They can even have seizures. Remember we talked about some causes, secondary causes of seizure activity. This might be one in a renal patient. And also sexual dysfunction. It can have problems with blood flow, problems with erectile dysfunction, etc. Okay? That would be under the high BUN and creatinine column. And then above that it says increased uric acid. So if somebody has hyperuricemia, that's also built up above normal. They can have joint problems. What's gout? It's arthritis. It's a type of arthritis. It's painful joints, particularly the big toe, and it's from high blood uric acid levels. So, and they can get urate kidney stones. They can get stones made of uric acid, which further complicates their kidney problems. So, anybody know the medication we give for hyperuricemia? Not colchicine, because that's specifically for gout. But in your typical patient with hyperuricemia, maybe a cancer patient getting chemo, for example, that can cause a lot of cell lysis and the uric acid can go up. The drug is allopurinol. And I believe allopurinol is the generic name. Allopurinol is given for hyperuricemia in a number of different settings, including renal. So, you look at the patient's MAR, because we have many thousands of people, especially in this part of the country, but everywhere, living now with end-stage renal disease, living with chronic kidney disease. And you look at their medication administration record, and it has antihypertensives for their hypertension, and it has a phosphate binder for their hyperphosphatemia, and it has some kind of calcium supplement, which may also be related to the phosphate binder. And it has allopurinol. And you can see that these meds are kind of, and it has some kind of a multivitamin. If it says Nephrocaps, that's a multivitamin for nephro patients, kidney. You'll see sort of typical medications, won't you? Yes?
For the exam, are we going to need to remember all the...
Things that go up and down?
Yeah,
I
the
would.
lab values again.
Not so much the numbers.
Okay,
Nobody's gonna say, what is the normal potassium level?
okay.
But it might say, what would you be on alert for in a patient who has severe hyperkalemia? Or if a patient has high phosphate level, what medication might you be giving them related to that?
Every semester I forget those levels.
Yes, make little flashcards, because you need them again in 2032. We're giving a test today, and they do have to know the electrolytes. Because you really do want to know your basic stuff. You want to know your basic CBC, H&H, WBC's platelets. We'll talk about that a lot when we talk about chemo and cancer. You do want to know your normal potassium, sodium, maybe magnesium, that kind of thing. So that when you see it abnormal on the patient's labs, you know you'd expect what to do and what they could be at risk for. On the NCLEX PN. The NCLEX PN, he's one of our PN grads from last summer. He took the NCLEX PN recently. And so for the practical nurses, you're expected to know the labs and what to watch the patient for. Is that right? Absolutely. So what do you think the RNs need to know? At least that, right?
That's right.
Bare minimum. Okay. So anyway, that's fine. Just keep working at it. You're a student. It's all right. Okay, now, to the right of that page there, the chart I keep holding up, my show and tell here. Okay, so we've done regulatory, we've done excretory. To the right it says endocrine. Now we know that that kidneys have an endocrine function too, right? So what does it say, what hormones, because that's the chemicals secreted by endocrine glands. So the endocrine pancreas, that's 2 weeks. The endocrine kidney function secretes what hormones? Renin. So renin-angiotensin helps regulate what?
Blood pressure.
Blood pressure. Blood pressure. Those are hormones that regulate blood pressure. What does erythropoietin? It's a hormone that regulates what?
Red blood.
Erythropoiesis, which is poiesis of erythrocytes. Erythro is red cells. So patients that have, what happens to patients' red cell count and H&H if they have chronic renal failure? They're very anemic. They're very anemic because they're not making and secreting the erythropoietin necessary for formation of red blood cells. So these folks are very anemic. They have very low H&Hs sometimes. But now, over the past 20 years, we have a magic medication that we give to patients with renal failure, and they often give it in dialysis. And it increases, it's synthetic erythropoietin. And it stimulates the bone marrow to make red cells, and it really helps their anemia. And what's that medication? Epigen, exactly. Epigen, EPO, Epigen. There's a long-acting one called Aranesp. They're the same thing. They are a colony stimulating factor for its synthetic DNA, recombinant DNA, very expensive, but hugely effective in management of anemia in patients with chronic renal failure. The Epigen or the EPO or the Procrit, same thing, it will stimulate the bone marrow to make red blood cells. So their H&H can really go up a lot. If that doesn't work, we can give blood transfusions. But we don't give nearly as much blood as we used to before we had Epigen. They're not using Epigen as much in oncology patients. We can talk about that later. But they use it a lot in the management of anemia from renal failure. Dialysis patients, right? You see it given all the time. Have you worked in dialysis? You've worked with renal failure. I know. Okay. So you've worked with patients with renal failure. Okay. Who are on dialysis. Good. So these are some things that the endocrine system manages. If you look below it, it says increased blood pressure, and that's, again, the renin-angiotensin system, along with the fluid overload. Patient will have headache, dizziness, blurred vision. That's from severe hypertension. Above it, it says decreased RBC, decreased H&H, which is what? Hemoglobin and hematocrit. And if a patient's anemic, they're going to have fatigue, dyspnea on exertion, pallor, etc. Okay, we talked about the treatment, which is generally Epigen. They can also give folic acid, iron sulfate. Those kinds of things will help to stimulate red blood cell production, because you need dietary iron and dietary folic acid, which is a B vitamin. You'll see that in sickle cell patients, a lot of folic acid, to help produce red blood cells. and also platelets.
I'm asking about the medication. Is it EPO or EPI?
Epigen. It's like, you'll see it used as EPO. They actually had it as a drug of abuse for long distance runners. Because what would help you run longer? More red blood cells. What do your red blood cells do? Carry oxygen to your tissues. So Epigen and Procrit, it's actually called something colony stimulating factor is the generic name. Colony stimulating factors, there's Epigen is for erythrocytes. There's one called Neupogen, what do you might think that would be for? Neutrophils, which are white blood cells. And then there's a couple for platelets that don't seem to work as well as Epigen and Neupogen. Very expensive, like $800 a shot. They're generally given sub-Q, although I have seen in dialysis they can give the Epigen IV push. But it's an injection, it's not a tablet. Okay. But it works.
Is that like a one-time thing? Or
No, you have to give it periodically. You have to monitor the H&H and give it periodically when the H&H gets low. It'll work this one works for about a week or two, and then they have Aranesp, which is 3 times expensive, but lasts for like a month or two. It's a longer acting. There's Neupogen, short acting for white cells, Neulasta for long acting Neupogen. So they have short and long-term versions of these. So whichever version you give determines how long it lasts. But it has to be given periodically. If the patient has no kidney function and they're not making erythropoietin, then this is going to have to be given periodically. Keeps that company in business. They make a lot of money. Amgen, I think, is who they are. Should have bought stock 30 years ago. I'd be really rich. Yes?
No, I was just fresh.
Okay. All right, so that's the endocrine function. So it affects blood cell production. It affects blood pressure. All right, so that's kidney function. Now, renal failure is if the kidneys don't function. Basically, if they've lost that, regulatory, or excretory and endocrine function, it's renal failure. So we're talking here mostly about chronic kidney disease or chronic renal failure. So what are the causes of renal failure? For acute or chronic, it could be any of these. Mostly for acute, it's decreased blood flow, hypoperfusion. So if you look across the top of your chart, they're there too. Causes. Pre-renal renal failure is generally from inadequate perfusion, which means the blood flow that goes into the kidneys before, which is pre-renal, the kidneys, is somehow impaired, by hypovolemia, by decreased blood pressure, by a stricture of the blood pressure, blood vessel. Something with the blood vessel is decreasing blood flow into the kidneys. And it results in kidney cell ischemia and something called acute tubular necrosis. If prolonged, the kidney cells will die. And it's related to, look at these things. They look to me like decreased blood flow, decreased blood pressure, hypovolemic shock, cardiogenic arrest or shock, septic shock, which means what? What causes septic shock? Infections. Lethal arrhythmias, which of course again would affect cardiac output. And bad dehydration. Bad dehydration can cause hypovolemia. People's blood, renal perfusion and urine output will decrease. Okay, now intrarenal. So pre is before, usually the blood supply into the kidney. Intrarenal is something inside the kidney. Yes?
Could that also be like if you have peritonitis where you have like third space filling with that?
Sure. Anything that decreases the intravascular volume. If you're having capillary leak syndrome or something's, peritonitis or something where stuff's not in the blood vessel, you're going to have decreased perfusion and decreased function. Yes. There's a lot of things that could cause hyperperfusion. Intrarenal is the nephrons themselves are damaged. So don't think so much about trauma, because I think that'll confuse you. Think about toxins. Think about medications. There's a lot of things that are nephrotoxic. What's an example of a category of nephrotoxic antibiotics where we have to watch renal function? Did you learn the categories of antibiotics? What about aminoglycosides? The mycins, genomycin, vancomycin, the mycins can cause nephrotoxicity. When you see that, so here's the deal on meds. We're probably going to start giving you some sheets to fill out with medications. and you're going to get a medication test at the end of the semester in lab. If you get it right, you'll get 1 point. On Blackboard, there's a place that says frequently used medications. Have anybody seen that?
Yeah.
Okay, print that off and start looking at it, because at the very end of the semester, we're going to ask you to know those medications, frequently used medications. And some of these are meds that you use a lot, like antibiotics, for example. And you might need to match the antibiotic with the side effect. And for aminoglycoside antibiotics, they are nephrotoxic, which means they can be toxic to kidney cells. And we need to watch renal function. And there's also something called renal dosing. If somebody has renal failure and they need an antibiotic, we have to give them less of it because it can be toxic. What are NSAIDs? Name these. Aspirin, ibuprofen, naproxen, lots and lots of them. Even Celebrex, which is now back, which is a COX-2 inhibitor type of NSAID. Non-steroidal anti-inflammatory drugs. Not acetaminophen. Acetaminophen is totally different. But NSAID, now acetaminophen or Tylenol is toxic to the liver. But NSAIDs are not completely safe. If the patient's getting a prescription NSAID, Voltaren or Relafin or one of those, and then they're popping ibuprofen, which is Advil or Motrin, or they're popping Aleve, which is naproxen, then they're double dosing themselves, and they can get GI bleeding, but they can also get renal failure. So we have a lot of people overusing and abusing NSAIDs. They're toxic to the kidneys. Contrast dyes. Some of the old tests we used to do, like an IVP, an intravenous pyelogram, we used to put, and you still see them, but we put a contrast dye, an iodine-based contrast dye into the bloodstream and then follow it on X-ray, as it, say, went through the kidney system or somewhere else in the body. But these can cause renal failure. They use it for cardiac catheterizations. Okay, there's actually a drug we can give to prevent the renal failure called Mucovis and acetylcysteine. Chemotherapy. There are chemotherapy drugs that are nephrotoxic. Kind of makes sense. They're cell poisons, so they have a pretty high toxicity or side effect profile. We'll talk about chemo a lot this semester. ETOH, again, now it's not just toxic to your brain and your liver, it also can be nephrotoxic, used in large doses. And then conditions like sickle cell anemia, don't worry about the seizures, I would cross that off too. We know that sickle cell is going to cell sickle in a low oxygen environment. So if they have a sickle cell crisis, it will clog up the blood flow, in this case through the kidneys, so people can get renal failure and end up on dialysis. Okay? All right. What's the 3 things we use to treat sickle cell? Three principles of treatment.
Yeah,
Hydration. You want to have lots of blood, they can put them on saline at 150 an hour, right? Hydration. What's the other thing? Pain management. That's the patient's biggest concern. And you need to use big guns. You got to use opiates, and you may need a lot of them. You don't withhold. You don't want to turn them into drug seekers. They need pain medicine. And the third one is oxygen, right? Oxygenation. Because you want to bring up the blood oxygen level as high as possible to prevent more cells from sickling. Okay. But anyway, these are things that can damage the kidney cells themselves, the parenchymal cells of the kidney. And then post-renal is something after. So it's usually something that's obstructing the rest of the urinary tract. What things can obstruct the urinary tract? The ureters, the bladder, the urethra. Stones. Kidney stone, urinary tract stones. Good. Pardon me? The prostate, either benign prostatic hypertrophy or prostate cancer, that keeps the urine from outflowing. If the urine can't get out, what's it going to do? Reflux back up through the ureters and cause hydronephrosis and kidney damage. Sure. What else? Strictures. Something where there's narrowing of a tube. In this case, it would be the ureter or maybe the urethra. Infections, bad UTIs can possibly damage that system. Mostly it's blockages. So, kidney stones, urethral strictures, prostatic hypertrophy, stones, and tumors. Some kind of a urinary tract tumor, bladder cancer, prostate cancer, something that blocks the outflow of urine from the kidney pelvis, okay? The kidneys have made urine, but now it can't get out. So if it backs up, it can cause kidney damage, okay? So again, acute chronic renal failure or acute kidney injury, usually hypoperfusion, could be obstruction of urine flow, but usually we're thinking about pre-renal. It's most likely pre-renal. It's reversible with aggressive treatment. And so we're going to do things like fluid challenge and maybe diuretics to help increase the perfusion. Now, chronic renal failure, chronic kidney disease, slow and progressive, irreversible, and they don't really develop end-stage renal disease until 90 to 95% of nephrons have been destroyed. Okay, don't worry about the 4 phases of acute renal failure. I don't think that's nursing. Chronic renal failure, the only thing I want you to understand is that there are stages. It can be diabetes, it can be hypertension. Also, some other conditions like lupus nephritis, can affect the renal perfusion. It thickens the basement membrane, kind of like diabetes does. And then the kidneys can't do their job of removing protein, breakdown products, electrolytes, etc. There's reduced renal reserve where the patient's still asymptomatic. There's renal insufficiency, and then less than 10% of nephron function would then trigger what we call end-stage needing dialysis or a kidney transplant. Okay? So by that time, their kidneys no longer do their job to sustain life. And now we have what we call renal replacement therapy, which is dialysis. Either peritoneal dialysis or hemodialysis, which we'll talk about. Okay, so we know with the impaired acid-base and electrolyte, so you've seen this now. What's elevated? Potassium, sodium, don't worry about low, probably going to be high in chronic renal. Metabolic acidosis, hyperphosphatemia with hypocalcemia. So that's what we call an inverse relationship. These actually go together. The phosphates are high, the calcium is low. So we want to bring down the phosphorus and increase the calcium. And then the impaired fluid balance, because it's fluid and electrolytes, would be fluid retention. So think mostly of the retention of fluids with chronic. The loss of endocrine function we talked about. Okay. Increase renin, increase blood pressure, decrease erythropoietin, decrease H&H, decrease metabolism of vitamin D, which can cause renal osteodystrophy, which can be the bones can be increased risk of fractures from the decreased vitamin D, which decreases the calcium. Don't worry about this slide. I didn't write it. It's not nursing. It's a heavy-duty pathophysiology slide about the renin-angiotensin system. All you need to know is it affects blood pressure. All this stimulation increases your blood pressure. This is a nurse practitioner slide that one of our NPs did. Okay? All right. The loss of excretory function, the excretion of protein waste products. We talked about increased BUN. What's a normal BUN? 10 to 20. 10 to 20. And so, patients that have chronic kidney disease, even with dialysis, they may not be able to get their BUN normal. They just want their BUN to be less than toxic. They may be running around 60, 70, 80. It goes up right before dialysis. It comes down a little ways after, but their BUN and creatinine may never go back to normal. You're trying to manage this chronic disease. You're not going to fix it. And then the elevated acids, the hydrogen ion excess, and the metabolic acidosis. Okay, so tests. We've talked about causes. We've talked about the function of the kidney. We've talked about what happens in kidney failure. So makes sense. We mentioned we want to do what? So the first one is to look at BUN and creatinine. Serum means it's a blood test. And what is the increased BUN and creatinine reflective of? Protein, urea, which is a protein waste product that builds up. Okay, this is the Y part that makes you professional RN. And then they can also do a 24-hour urine for creatinine clearance, and they can match that with the serum creatinine. I don't see as many 24-hour urines anymore. I think part of it is because nobody ever did them right. I mean, they're really hard to do correctly. Even the patients that do them at home, which are probably more careful than the ones in the hospital. And also we have other ways to get at the same data. But they can do a 24-hour urine, and that's reflective of what? It's reflective of glomerular filtration. It can give them a pretty good idea of the GFR. A KUB is just a kidneys, ureters, and bladder x-ray. A CT scan, of course, is computerized tomography, with or without contrast. They can do a renal ultrasound. What do they do that to find? Stones, kidney stones, nephrolithiasis. You like that word? Nephrolithiasis, kidney stones. The IVP is where they put the contrast dye in and an X-ray that goes through the bloodstream, through the kidneys, and out through the urinary system. And renal arteriograms, which is the blood flow. Okay. Now we do also a lot of MRIs, which is a wonderful non-invasive test using powerful what? Magnets to get the picture. So we don't have to do as many invasive tests, which is great. We're going to do a lab on diagnostic tests, and you'll talk more about that kind of stuff. MRIs, PET scans, IVPs, mammograms, colonoscopies, all of that. Okay, so the classic medications now. Oh, that's the one I was trying to think of, not Bumex. Lasix and mannitol. Lasix and mannitol are, of course, diuretics. We said that Lasix, or furosemide, is a loop diuretic. What does it do to your potassium? Decreases it. Mannitol is what kind of diuretic? It's an osmotic diuretic, right? Which means what? It's an osmotic. How does an osmotic diuretic work? Yeah, but how does it work? When I said osmotic, does that mean anything to you? It means it's going to pull fluid into the vascular system. It pulls fluid. They use it for increased intracranial pressure because it pulls excess fluid in the brain into the vascular system, which then increases your blood pressure, but it also then is a diuretic because it will flush the kidneys. So these are both used to help increase renal perfusion in a patient with acute renal failure, acute kidney injury, whatever you want to call it. What if a patient has end-stage renal disease and they're anuric and they're on dialysis? What does Lasix and mannitol do? Nothing. Nothing. So your nursing intervention for somebody with end-stage renal is dialysis or kidney transplant. If they don't have kidney function, diuretic won't do anything. It can't help you if you don't have the function. It's got to have something to work on, right? So that's just for acute. Now, a lot of patients with, well, pretty much all patients with chronic kidney disease have hypertension, right? So Catapress. Catapress is actually a brand name. What's the generic name for Catapress? You'll see it used for emergency or really high blood pressure. Clonidine. Clonidine. Catapress is clonidine. Then we have our calcium channel blockers. Now, unfortunately, calcium channel blockers don't have a end that you can pick. It's Norvasc, which is amlodipine. It's nifedipine. Actually, I guess it's penes. A lot of them are penes. Nifedipine, amlodipine. Those are calcium channel blocker antihypertensives. The other next category is what? Look up there with me. Beta blockers. So what do we see at the end of the generic name in the classification of beta blockers? OLOL, alols. Metoprolol, atenolol, propranolol. So beta blockers are alols. They decrease your blood pressure also. And what else do they decrease? Beta blockers. The heart rate. The heart rate. Okay, good. So that needs to be taken into consideration. And then you can also use, and some of these patients are on multiple antihypertensives. You can try monotherapy, which is one, but if that doesn't work, you add another one and then another one until you get blood pressure control. Although mostly with dialysis patients, it means they need dialysis. Okay, ACE inhibitors. What's the generic classification ending on those meds? Pril. Pril, P-R-I-L. Lanapril, lisinopril. Right, ACE inhibitors. Okay, so you got to know the generic names and you got to know the classifications. So that's the only way you can learn meds is by classification. Because the side effect profile of a group of meds is pretty much the same for that classification. Corticosteroids, beta blockers, whatever. And then the meds exchange resins like Kayexalate are used to do hyperkalemia. So you're giving them for a very high elevated what? Potassium. And it's going to pull in, it's an ion exchange resin, and it'll pull in potassium. Again, they can also use insulin. Insulin. If you give the insulin to decrease the potassium, you also have to give the D50 to rescue what? The hypoglycemia. You have to give them, you're going to drop their blood sugar too. And you don't want that. You want to drop their potassium, but you give the D50 because of the hypoglycemia caused by the insulin. Yes?
So you probably wouldn't give KX-late and Lasix to the same patient because that's going to bottom
It depends.
potassium?
It depends. If the patient has chronic renal failure, you're not going to give them Lasix anyway, because it's not going to work. But you would, if your patient was getting both, you would want to monitor that closely. Yes. The KX-late might be more important. You might or they may stop the Lasix. Yeah. Because hyperkalemia can kill somebody with dysrhythmia. So if it's really high, they might have to go with whatever's the most important. Foslo or Renagel are used to decrease calcium deficiency, but also to do what? Lower the phosphate. Yeah. Foslo, Renagel are phosphate binders, but they're also calcium supplements. And then aluminum hydroxide or Amphigel, some of those are also given to help with the phosphorus, the hyperphosphatemia. And, well, I think there's another page. Yep. And we're going to give biologics, biologic drugs, which is by definition recombinant DNA technology. You'll see the biologics now, totally different category, advertised for autoimmune diseases like rheumatoid arthritis and Crohn's disease. That's your Enbrel, Remicade, Humira. Those are also DNA technology and very expensive. But these are biologics called colony stimulating agents. So they stimulate the production of, Epigen stimulates what? Red blood cells. And Procrit is basically the same thing by a different company. And then Neupogen, which is for neutrophils. The generic name is granulocyte macrophage colony stimulating factor. That's the generic name for Neupogen. Even more expensive than Epigen, but it's wonderful for patients who are what? Neutropenic. Neutropenic because the neutropenic patient can die of what?
Infection.
Sepsis, right, infection very quickly. And then folic acid, iron supplements, those kind of things are given because of the anemia. Folic acid is a B vitamin. Iron, of course, also is important, ferrous sulfate. So the nephro caps that you'll give, the vitamins you'll give renal patients, kidney disease patients, often will be given to help with their anemia in addition to the Epigen. Okay? All right, so break time. We did a lot in an hour. We will talk about dialysis a little bit here, and then you're going to have a lab this week at dialysis. So after that, you should be pretty up on dialysis and managing patients with chronic kidney disease. But again, look how wonderful this little picture is. It even has under, you know, the increased sodium or increased potassium, the signs and symptoms. So it not only has the causes and the kidney function, but under the increase or decrease, it has the signs and symptoms. As I said, the only thing not on this chart is the actual nursing interventions, which is very important. There's a slide at the very end of this, after we talk about dialysis, which says nursing care. So this is really the crux of it here. Based on your chart, you can look on here and you can identify the nursing care. You want to avoid aspirin products, which includes all NSAIDs, right? Isn't acetylsalicylic acid an NSAID? Okay, it can actually build up and cause a white crystalline acid. It can increase the acidosis. Acetylsalicylic acid, right? An NSAID. Increase libido, the sexual dysfunction, because of the elevated BUN. Also decrease perfusion probably, but they can get neuropathies. KX-late is for the hyperkalemia. Lab findings, I'll come back to teaching in a second. Elevated potassium, low calcium, and high phosphorus on serum testing. Physiologic integrity. Control pruritus. Now, what causes the itching? Increased phosphate. But for managing it, they could give antihistamines. They can also do, you know, symptomatic treatment like oatmeal baths. Back in the day when people didn't have good dialysis, they actually could develop what we call the uremic frost. You might still see this in countries that don't have a lot of good renal failure treatments, where their BUN got so high that the uremia was excreted on the skin, and they got like a white frost. They're pretty close to gone by then, but that could happen. Safety, risk for injury, falls. Safety is always a priority. Now, disequilibrium syndrome is a side effect of hemodialysis. We'll talk about that in a minute. Dietary, before you take your break, you're going to tell me what the classic renal diet would entail. And then we'll take a nice long break.
Decrease sodium.
This is the classic diet. Now, when you read your book,
Decrease
they
sodium.
talk about some dietary, you can relax some of these restrictions if they're on dialysis. But the classic diet for somebody, say they're renal insufficiency and they're not on dialysis yet, what do you want to decrease in their diet?
Sodium.
Sodium.
Decrease sodium. So they need to know what foods are high in sodium so that they can
Canned
avoid them.
foods.
Right? Now, you've all learned about what foods are high in sodium. You know that canned foods and processed foods and a lot of those things are high in sodium. Did you know that salt substitute is potassium? So
Yeah.
they can't do that either. Because we also may want to have them have a decreased potassium diet. And there are foods that are high in potassium that they should avoid. So they should avoid, well, I have a decrease arrow. Decreased sodium, decreased potassium. And we know that potassium-rich foods are things like, what? We all know about bananas. Oranges,
Oranges. Yeah.
potatoes, green leafy vegetables. You know, they actually, if you go on some of these websites, I'm going to write this up here now so I don't forget. Well, there's a couple of major national dialysis companies. They're pretty much all dialysis, including in hospitals now, is pretty much run by these companies. It's either DaVita or Fresenius. Those are the two big ones. They hire a lot of nurses. And they have a lot of wonderful things on this website, including if you take your potatoes and soak them overnight, it pulls out the potassium and you can eat them. You know, really cool stuff like that. Okay, so what else would be restricted? Fluids. Yes, thank you. I want you to do this one too. You just said it. Protein, right? So now we have restricted protein, restricted fluids perhaps, restricted sodium, restricted potassium,
You want to increase your
Carbohydrate.
calcium.
calcium,
And they do use, you have to get your calories somewhere.
vitamin D.
Now that could be a problem if they're diabetic, but yeah, calcium, vitamin D, which often are given together or used together. Okay, so this is about the only thing they can really eat.
What about like folic acid and iron?
If you could do folic acid or things that help with red blood cell production, that would be good. So this is your classic renal diet. It's restricted, and the reason I say classic is because once they're on dialysis, some of these restrictions can be relaxed. It's very hard to have a zero protein diet. It's very hard to have a severely fluid restricted diet. All of these things, I mean, if you're just trying to do decreased sodium, that's not that easy. But a lot of these, this is the renal diet or the kidney failure diet. Okay? All right, so you also need to then think about and understand what foods would be restricted in this diet. Okay, all right, I keep saying break, let's do it. Go. Come back at, let's do 20 minutes. We'll do 10:40. You'll probably get out a little early today. Well, we're going to talk about dialysis before that. And a little bit on kidney transplant. Okay. I'm going to talk just for a few minutes. We're going to go through the information on dialysis, which your book does do a good job with. I know it's a lot, and it has good pictures and things. And then we're going to do more with dialysis in lab, okay? So I'm going to run through this, and then we're going to do a quick exercise, and then you can see your test for lab. All right, so when the kidneys no longer function, replacement therapy is needed, renal replacement therapy, and that is dialysis. It's indicated when the patient can no longer be managed with conservative therapies, such as diet, medications, fluid restriction. So there are people with renal insufficiency who no longer have, who don't yet have end-stage renal disease and are not yet on dialysis. But when they get to that point, that their kidneys don't function and they have buildup of toxins and they are symptomatic, then they need to go on dialysis. And in dialysis, the blood is cleaned and filtered. The nitrogenous waste products are removed. There are fluid balances re-established. And dialysis uses the principles of diffusion, osmosis, and hyperfiltration. Now, I know the LD5 group is going to get a day where they can go to the dialysis unit with the dialysis nurses. Even if you don't, you still have a dialysis assignment, which I would recommend that you look at now, between now and the test. And it goes through and asks you to, again, not a nursing question, but it asks you to define diffusion, osmosis, and hyperfiltration. Okay? The patient is what we use to determine dialysis and need for dialysis. The therapy depends on their symptoms. How do they feel? How do they function? Not just their labs, creatinine clearance, but if they have fluid overload and they're short of breath because they're getting some pulmonary edema, which is from heart failure, right? If they have pericarditis, uncontrolled hypertension, neuro problems, uremic manifestations, which could be a level of consciousness, itching, etc., nausea and vomiting, again, LOC, cognitive problems, worsening anemia. So these patients would be then candidates for hemodialysis or peritoneal dialysis. Those are the two types of dialysis that are available. The vast majority of patients these days are on hemodialysis. Hemodialysis is usually done in an inpatient or outpatient dialysis center, but now they can also do it at home. They have these AV grafts and fistulas that they can put in with a little button, and they can hook it up and do their hemodialysis at home. But the principle is that the blood, hemo, is taken out of the patient, passed through the machine, and back into the patient, right? The blood is passed through an artificial semi-permeable membrane. So at the top, there's a picture. You can see to the left, there's more pictures and better pictures of the kidney, which we'll show you in lab, where the actual dialysis takes place. The blood goes through one way. The dialysate solution, which is hypertonic to the blood and pulls in fluid to the dialysate, goes the other way. Blood and dialysate, which close to the dialysate resembles human plasma, flow in opposite directions. The waste moves from the blood to the dialysate by osmosis. The filtered blood is returned to the client. So one hemodialysis treatment is 4 to as many as maybe 6 hours. The machines are better now. They are faster. I've seen patients in a little under 4 hours get a full hemodialysis treatment where they pull off the amount of fluid. Again, the settings are ordered by the doctor, but the treatment is done by the nurses and the dialysis techs. So this process is handled, managed by, the patients are managed by the nurses. The RNs are the ones that, give the meds, manage the hypotension if it occurs, do the patient teaching. They do a lot. They communicate with the doctors, but the doctor's not necessarily there, usually is not there. The nephrologist, the doctor that manages patients with kidney disease. The system has a dialyzer, dialysate, which is the fluid. The lifeline for the patient is their vascular access route, and then the dialysis machine. So here's just a diagram of the blood being removed. They monitor the blood pressure. They heparinize the line, just like they did with, say, a Portacap to prevent clotting in the line. They monitor the pressure in the system. The dialyzer, or the artificial kidney, is that long tube with like thousands of little tubes in it. Goes back through an air trap detector, and then the dialyzed clean blood is returned back to the patient. Here's another picture. You can see the top right there is the actual artificial kidney. Those are disposable. They're only supposed to be used once. I remember days when the chronic community dialysis places, some of those patients would use their own artificial kidney more than once, but that's illegal. Very strict regulations for cleaning, for for disposable systems, etc. Because you have that patient's blood out of their body. Another thing is way back in the day, before the hepatitis B vaccine, a lot of dialysis nurses got hepatitis because of the amount of blood that they were exposed to. So the nurses have to be very careful to use standard precautions, which is all it is, unless the patient has MRSA or something, and then those are done in an isolation room. But anyway, the patient's blood is taken out of the body, filtered, and given back to the patient. That's hemodialysis. So for hemodialysis access, the patient has to have a way to get the blood out of them through the machine and then back. So there are a couple different pictures here. The top one is an arteriovenous fistula. Well, actually, this is the arteriovenous graft. So the surgeon in the OR takes a piece of grafting material and uses that to connect the artery with the vein. Okay? And in the fistula, these are even more common. The surgeon will take the vein and anastomose it or attach it to the artery. And then they'll have a large vessel that they can cannulate when they put them on the machine. The nurses and the techs putting these large needles in, 2 large needles, one to get the blood to the machine and one to give it back. You need a large bore needle. You need a low number because you got to get a lot of blood out fast and get it all back fast. So they're like 14s. They're very large needles. And that's what the nurses and techs do all day. They put people on the machines, which means they have to stick them in their AV graft or fistula. Okay. So how do we know the patency? You're not a dialysis nurse, okay? Only the dialysis nurses will cannulate or stick these things, the AV graft and the AV fistula. But you're the floor nurse. How do you know that their access is patent?
Roots and the thrill.
You do what with the thrill?
You feel it.
You hear the bruit, you feel the thrill. Remember, feel the thrill. Okay, so when you touch the AV graft and it's patent, which is good, you feel the thrill, and it feels like a buzz. It's the arterialized vein. It's the high pressure blood going through a low pressure vessel. So you want, in this case, to feel the thrill. And you also want, in this case, to hear the bruit when you auscultate. And you're hearing that high pressure blood go through the low pressure vessel. Otherwise, is a carotid bruit a good thing? No, what's a carotid bruit? It means your carotid arteries clogging up. And you'll hear the high pressure going through the clogged up vessel. Bruits are bad except in dialysis grafts and fistulas. Then it's good because it means it's patent. If you don't hear the bruit, feel the thrill, what do? Call the doctor. That's the answer. Sometimes that is the answer. Okay. So that's what this says. And there's good pictures in your reading. So in the fistula, the artery and vein are connected together. In the graft, there's a soft plastic or some type of tube inserted to connect the artery and the vein. They both are the same principle. They're to get the blood out in a large bore needle through the machine and back to the patient. So this is very important. Then there's also the neck or chest catheters. You'll see Quinton catheters, permacath. Do not confuse a permacath, which is a dialysis catheter, put in the neck usually, with a portacath, which is just for IV fluids. A dialysis catheter will have an arterial side and a venous side. Sometimes they're red and blue. Red would be artery, blue would be vein. These are central lines. They're put into the neck or the chest, and they're only used for dialysis. Don't get me into trialysis catheters for IV fluids. They have those now too. So these are for dialysis only. So what do you think would be the risk? Well, it's in red. Okay. It's in red right there. So the central catheters, the permacaths or the Quintons, are surgically placed. They do work. They're used if the patient needs dialysis immediately, because the AV grafts and fistulas take a couple weeks to mature, to heal, before you can access them. So in the meantime, they can get a Quinton or a permacath. Unfortunately, some patients over the years have used up all their veins and arteries because they've lost their AV fistulas or fistula. Anyway, they've lost their arm accesses. They've blown, or they've gotten infected, or they've gotten, permanently occluded, and they run out. So those patients over the years you might see with a permacath or a Quinton, a central line.
Are they usually primarily temporary though?
They're usually primarily temporary. They're supposed to be for short-term use until they get an AV graft or fistula, and it matures, yes. And in red it says what? They're more likely to get infected than the ones that are under the skin. They're easier to access, but because it's something sticking out of the patient's body, they're more likely to get infected, and the patient could get septic. Okay, so they look like that. So that's, in a nutshell, hemodialysis. Blood comes out of the body through some sort of vascular access, through the machine, back to the patient. And we'll look at the website, I think, in lab, where they'll show you that they have the nocturnal places people go. A lot of these are now in the community. In a place like Baltimore, in a place like DC, there are a lot of community dialysis centers. As you get further away from the cities, there are less of them. Some people can go in at night. Some people can go in before work. Some people can, they're usually 3 times a week, right? Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. Patients can get it as an inpatient if they're in the hospital for something, or they're just recently diagnosed, or they're in ICU, they'll take the machine to ICU. Some patients will go to the community centers. And then again, they even have home hemodialysis for patients that qualify and have the ability to do that. Okay, so we'll look at that later. It also has cool stuff about diet. So peritoneal dialysis. So what is the dialyzing membrane where the fluid and waste product transfer takes place in a patient undergoing peritoneal dialysis? What is the dialyzing membrane? The dialyzing, in the hemodialysis, it's the blood passing through the artificial kidney in the machine. In a peritoneal dialysis, there's no artificial kidney and there's no blood. So you take the dialysate, which is a fluid, and where do you put it?
No, in a space.
Where's your peritoneal cavity? It's your abdominal cavity. It's your abdominal cavity. That's what peritoneal means. So it goes from, the fluid goes into the patient, hanging on an IV pole. It goes into the patient's belly, not their stomach, but their abdominal cavity. And the dialyzing membrane becomes the peritoneal membrane, the peritoneal cavity. Okay? It dwells in the peritoneal cavity. That's when the dialysis takes place. And then it's drained. Okay? There's 3 types, but the principle's all the same. Continuous ambulatory peritoneal dialysis, which you'll see the patient with in the video in the lab. He puts in his dialysate, he goes about his business, goes out shopping, goes to work, whatever, comes home and drains. There's the cyclic, where they hook up to a machine, the machine does it, maybe at night. Turns on the inflow, leaves it to dwell, whatever time is set, turns on the outflow. That cycle finishes, inflow, dwell, and outflow is a cycle, and then it goes to the next bag and it does it again. Or there's just a regular manual done by the nurse. Okay, so a patient with peritoneal dialysis is going to have a catheter that comes out of their abdominal cavity, a Tankoff catheter. That's what is used to get the dialysate into the peritoneum and then to drain out. So the fluid that goes in is clear. The fluid that comes out should be fairly clear, maybe a couple little red cells, but normally clear. If the fluid that comes out is cloudy, what might the patient be developing? Infection. So what is the most serious complication and reason for discontinuing? Peritoneal dialysis. Peritonitis. Good. Good. Peritonitis. Okay. We're going to talk more about that also in lab. You inflow, you dwell, and you outflow. The effluent is the outflow. So here's a quick question for you, because you'll seem really smart in lab. If you use the dialysate fluid that's hypertonic to the plasma of the patient, are you going to expect to have more fluid out than in?
Yes.
Or less fluid out than in?
More fluid out.
Than in, because there's hypertonic dialysate, you also want to be pulling fluid into the peritoneum and outflowing, which makes sense because you want to pull fluid as well as wastes. So a hypertonic dialysate, hypertonic to the plasma, is going to pull fluid. And however much fluid you want to pull, the doctor will order different tonicities of dialysate. Okay, good answer. Okay, and then the cure, if you will, for chronic kidney disease, end stage, is a renal transplant. Kidney transplants were one of the first really successful organ transplants done in this country, and it's been a long time. And now it's become relatively routine, and you'll see these places where they'll have 5 or 6 people matching up with someone else, donating a kidney, and giving a kidney transplant to someone. We still use a lot of compatible cadaver kidneys, meaning somebody who's brain dead, the patient and family gives consent for that kidney to be transplanted. They keep the patient perfused, they harvest the kidney, and then they send it to whoever matches. So some fortunate end-stage renal patients can find a matched kidney from somebody who's donated their kidneys, which gets into all the things about donating organs and how important that is, and how important it is to be an organ donor, and how important it is for your family members to understand how important it is to you and your community for people to donate organs. Because there are some cultures where it's problematic to get transplants because they don't have enough genetic matches, because either the community is not cooperating with organ donation, or there just aren't people that are willing to donate. So the majority of all organ transplants, kidneys, livers, hearts, lungs, etc., come from people who have given consent for their organs to be donated. And not only is it on your license, but then your family still has to understand that that's what you want and give consent. Because you get in these issues where, the patient is in ICU, the patient is young, the patient would be a wonderful candidate for organ donation, the patient wants it, it's on his license, and then grandma makes a big scene and blows the whole thing. Because the doctors are not going to go up against the attorneys, the lawyers, they're chicken. The Transplant Consortium people do a really good job of explaining, comforting, supporting, explaining again, comforting, supporting. But if somebody in the family says no, they won't do it, even if the patient wanted it. But anyway, I digress. A lot of kidney transplants now, because people have 2 kidneys, actually come from living donors. And you see the stories as usually it's a family member. You'll donate for your child, you'll donate for your spouse, but sometimes it's the teacher, or it's the neighbor, or somebody else that wants to do it, and will donate a kidney, a live donor kidney. Okay. Now, interestingly, surgically, they don't take the old kidney or kidneys out. They'll leave them there, and they'll suture the donor kidney into the pelvic bowl and attach it. Okay, so nobody's going to ask you questions about the surgical technique for kidney transplants. That's not nursing.
Why don't they take the old one out?
Because they found that they don't need to, and it's more risk of surgical complication if they do. And usually there's some problem with the blood flow into the kidney, and you don't want to attach it there anyway. But also mostly because they don't want to do any more surgery than they need to, and there's a place to put a new one, and then in the pelvic area, and then they just attach it. And it works fine. So they walk around with 3 kidneys. The one that works and the 2 that don't. Yeah. And recovery is the same for any post-op client. Usually it's like 5 days, maybe not even that long these days. You can get a cardiac bypass, a cabbage, and be home in 4 days. So certainly for a kidney transplant, you could go home in 3 to 4 days or 5 days. And like any other abdominal surgical patient, there's restrictions on lifting, driving. They don't want them to hiss. And of course, then they also want the transplanted organ, which is hopefully matched, but they're still going to be on anti-rejection medications for the rest of their life. Any organ transplant patient is on anti-rejection, which does what to their immune system? Suppresses it, which makes them immunosuppressed. That's the intent of the immunosuppressant therapy. And these meds are reviewed, maybe adjusted. Patients seen by a transplant nephrologist and a transplant coordinator, who's usually an RN. And then people have access to the people on the team that did the transplant. Now, the worst case scenario is that it doesn't work, that it rejects. And you'll see some renal failure patients, say they had type 1 diabetes and they went into end-stage renal disease in their 20s and they had a transplant in their 30s and now they're on their second transplant in their 40s. If the patient rejects the transplant, they're going to have symptoms of returning renal failure, which would be oliguria, fluid, retention, increased blood pressure, weight gain, swelling, maybe tenderness of the transplanted kidney, maybe fever from inflammation or infection, and then increased serum creatinine levels, which means the kidney's not working anymore. So, of course, there's the usual post-op complications, which could be infection, and then there's the rejection. So rejection can happen any time after the transplant. And so hopefully, in many cases now they do, people live the rest of their life with their new transplanted, normally functioning kidney. This is a slide about immunosuppressant anti-rejection drugs. Drugs that they use for kidney transplants, for liver transplants, for heart transplants, for lung transplants, for anything, because you want to prevent rejection. So Imuran is an old one, as a thioprine. Corticosteroids, like prednisone, and your classification of steroids often ends in SONE. So what are the two major things that we give steroids for? The usual thing is for anti-inflammation, but we can also give it, and sometimes you'll see that in autoimmune diseases, or in this case, anti-rejection, because they are immunosuppressive. Now that's a bad thing if you don't want that. Don't we say this corticosteroid therapy can increase your risk of infection?
Yes.
They are. They're great anti-inflammatories. They're still the best drugs we have for severe inflammation. We give Solumedrol for your lungs. We give dexamethasone for your brain. We give prednisone for all kinds of things. And it's wonderful for inflammation, but it also is it's also an immune suppressant, which in this case we want. The cyclosporins are old anti-rejection immunosuppressants. There's some newer drugs like Prograf, which is tacrolimus, which is like the cyclosporines. There's a drug called Cellcept, which they use to prevent transplant rejection. I've also seen it used in lupus nephritis. Patients have autoimmune disease like lupus. Some of the newer monoclonal antibodies. When you see a monoclonal antibody, which the research came out of cancer research, if the generic name ends in MAB or NAB, MAB is monoclonal antibody. And those can also be used for anti-rejection. The bullet at the bottom says if rejection occurs, hemodialysis is resumed until another transplant can occur, and the patient goes back on the National Computerized Transplant Registry list, okay, until they find them a donor. All right, and then here's that last nursing care slide. So, I think it's the last. Is it?
Yeah.
Yes. So, when a patient has renal failure, these are all parts of it. Again, the classic renal diet is, just know the classic renal diet. Don't worry about how much more protein they're allowed to eat if they're on dialysis. We don't care about that. Know the concept and be able to apply it. So here's what we're going to do for the next 15 minutes. You four are going to do the yellows. Although there's a green that's really yellow. You four are going to do the greens. You four.
Us over here.
No, turn around behind you. You two can do the orange. Actually, sit down, you're with these guys. Because we have a bunch of hands. You guys are going to do the reds. What little bullet? It has blue. Oh, sorry. All right, so here's your sections. Remember you've got your chart, and it has your signs and symptoms under the pathophys. You're going to do the nursing management of these symptoms. And you're going to put it up on the board, and it's going to stick. So, let me give you some markers. So, used to use chalk, actually.
Just take one.
So the people who have yellow, this is your psychosocial and coping. Okay, so you can have black. Who has red? Red is oxygenation. Okay. Who has green?
Yeah.
Green is food and fluids. Who has blue? I don't have a blue one. I couldn't find my blue marker. But anyway, so I think I'll give you. I hate to make it another red, but I guess we'll have to. All I seem to have is red and green. I'll use green. You guys are elimination. So I want you to, in the next, like 5 minutes, each divide them up. Everybody take one. You might have two if you have a small group. Divide them up. And then you're going to come up here, and you're going to put them on the board, and each group can just talk about it. Bring them up. I'm going to do the yellow first, but we're only going to do that quickly.
How about the orange?
The orange, you guys are safe environment. Safe, comfortable environment, sorry. Safe, comfortable environment.
So what nursing introduction? Procedures.
I'm going to put the DaVita website back up in lab.
So the lab is allowed to talk about why.
Yeah, you're going to come up and you're going to, well, the symptoms are self-explanatory. I want you to give me the nursing management. The nursing and medical management for that symptom. The management for that symptom. The nursing medical management for that symptom. And I'm sorry, that one's supposed to be yellow, but
It is yellow.
yeah, it's yellow. It's yellow.
Okay, so
So divide up the symptoms, look it up on your little chart. Don't really have time to do a big literature search of your book. But just talk among yourselves, and then be ready to come up.
all right.
It'll be fun. We're going to stick them up
Need to
here,
rest their sleep. What would we do first?
and I'll write underneath them.
We would.
But don't worry about the markers.
And
What do you think the nurse and doctor would do to manage these symptoms?
okay. So we're going to.
We're still going to have time at the end to look at your testimony.
Visitors, list, put them in their own room down the hall, quiet room. We're going to decrease stimulation. Alright, what's the next one?
Yeah, keep it simple. I think I'll just do the writing with
You
a black
give
pen.
the
Benadryl.
Benadryl. Yeah, this is
Faster.
right. There's no more.
Blood pressure.
Maybe, yeah, radiation,
On their
lower the
ability
bed,
level.
or have the call like the side. I'll prevent the clutters,
diet and
the
medication.
rugs. Is it
Okay. Give those
She didn't know. I don't know.
paper, so they can review on their own, so paper.
Always rearrange or redirect.
redirect, redirect.
What's the next number? Depression, anxiety, grief.
What else? That's it. Should we start now? Miss A, can we get started now?
You ready?
Yeah.
Yeah, okay. Here, I'll help you put them up there. Who did I give the black markers to?
Side rails,
Okay.
padded.
All right, I'm gonna
I
write
did that.
Yeah, I don't know how you're gonna get out, but let them through. Okay, this is your safe and comfortable environment.
Okay. Depression, anxiety, grief, and denial. Determine which they're in. Oh, knowledge deficit, you can check for a language barrier too, here.
Okay. So what did you say for, just tell me which one.
And you can be empathetic,
Okay, that's seizure precautions?
ask open-ended questions to get to the root of the problem.
What else?
Coping mechanisms. Yeah, I have that. I have that here.
Okay.
You can refer to a therapist,
First, you're gonna lower them to the
refer to
floor, right?
counseling.
If you would. Okay. What else? That's enough.
And
Okay, okay. All right, so.
counseling,
What else?
asking them open-ended questions.
Reorient.
Body language. Altered body image. And
All right, what about the?
well, I think these are just examples. These are just examples. So what would you do for someone with altered body image? You could
You mean clutter?
You'd ask them what exactly, what their problem is, like what is the reason for it.
What about paralysis?
Yeah, I just think that these
Can't hydrate, I'm sure.
examples, I think just to give you an reason why
Okay, very
you
good.
can get refer to counseling.
All right, I need my big yellow one there.
That's us.
All right, you guys come on up.
That's why I can find this because this is P.
Oh, really?
Wait, P? No, oh, this t-shirt but has P. I saw P.
All right, so what do you want to say?
Well, we can
Oh, when it's children that having.
ask them about their sleeping patterns. We have limit visitors.
Where are the post know that?
Yes.
What about sleep hygiene?
We have a quiet room, decreased stimulation.
Okay. All right.
Quiet room in the hall, just so they're isolated.
Okay. All right. Maybe that's. Okay. What about over here? Menstrual dysfunction. There's erectile dysfunction meds. You're also going to monitor their BUN and creatinine as the protein buildup can cause this. And support, concerns, referral, depression, anxiety, grief. All these things are what? Living with a chronic illness. Therapeutic communication, which includes open body language, open-ended questions, and then referrals to counseling. Sleep pattern, sleep hygiene, decreased stimulation, quiet room, maybe sleep meds. Knowledge deficit, all the patient education, know their patient, their level. Handouts if they're literate. Make sure you have the correct language, diet meds, and all the management. Okay, now over here is oxygen, right? So if you have decreased H&H and you're anemic, you want to know their labs, especially their H&H. You want to give them meds like Epigen, packed red blood cell transfusions, folic acid. They may need oxygen, and they need a safe environment. And also rest. Forgot rest. All right. Hypertension, monitor their BP. Give the meds, monitor the meds, rise slowly from a sitting position, and no meds prior to dialysis. Monitor their labs, their clotting times, and use bleeding precautions. Pericarditis, monitor their heart and vital sign function, and they actually do give NSAIDs, although we probably wouldn't want to do that if they have renal failure, so I'm crossing that off. Easy to fix. Okay, hypotension during dialysis it could happen, or with acute kidney injury, acute renal failure. And in that case, they actually do give fluids, including during dialysis. All right, over here, we have the blue. So if they, this is the elimination. If they have oliguria or anuria, you're going to do daily weights. They do weights before and after dialysis. They do dialysis and they can give meds. You're not going to give fluids because their kidneys don't work. Diuresis and polyuria is mostly just with acute renal failure. Okay. Urinary tract infections, you're going to monitor their urine, do a culture and sensitivity, and antibiotics if necessary. Constipation or diarrhea, high fiber diet. Remember, you can't give fluids. And meds like Imodium if they have diarrhea. For decreased calcium, increased calcium diet, calcium supplements. For the increased phosphate, increased phosphorus, drugs like phosphoenredigel, manage the itching. The itching is also managed over here with Benadryl and oatmeal baths, and managed pain. Decreased protein diet, dialysis, monitor BUN and creatinine. Over here for edema, fluid restriction, diuretics if the kidneys function, otherwise it won't work. Monitor their BP and monitor them for fluid overload, like wet lung sounds. Over here, up here we have safety. If they're at risk for seizures from the high BUN and creatinine, you want to have them on seizure precautions. If they have a seizure, you lower them to the floor and loosen clothes. If they're confused, you reorient, prevent falls, maybe a clot. For blurred vision, remove clutter, good lighting. For pruritus, Benadryl and oatmeal baths. And that's it. For thirst, you would do hard candies, ice chips, and mouth care. You can't do fluids. For potassium, you monitor cardiac rhythm and their K levels. Give K-Xylate or insulin if it gets really high. And I think that is it. All right? Good job. Oh, yes. I want to see if there was a case study in there, but I decided to quick do this. All right. Your tests. You can look. You have about 5 minutes to look at it, or if you want to stay here, if you want to. That's the antibiotic. Okay, Rosa. William. This is LV1. William. Now, the report that the benchmark scanner was supposed to make didn't make. It's done. Blessing. Yeah. Okay. So what you got is your actual Scantron sheet, and then you have the test paper itself. Elizabeth. So on the Scantron sheet, if you got a little red mark to the right of your item, you got it wrong.
I'm kidding.
Also, you got your actual test, so you can see how you did on those last questions. LV5. Christelle. Nana. Esther.
Yes.
Is Ashley here today?
No, I'm sorry, I just called her. She said she wasn't feeling well.
Okay, Jessica. Tina's in the back. Ashley's not here.
Did you say you had
Ollie, mommy? Brady?
There's a little red mark.
You missed this too, okay?
I am. The red marks are the ones you got wrong.
How will we know?
I'm going to put it up real quick.
I missed two.
I have this. So we're going to have to put this up on the, well, actually, let's just go over it. Everybody with me? Got your, open your test booklet, because that's how you see the actual question, and then look at your Scantron. The answer to number 1 was B. Okay, here, follow it. Triad symptoms. The answer to number 2 was A. The anal sphincter reflex returns at the end of spinal shock. The answer to number 3 was D. The answer to number 4 was B. The answer to number 5 is D, as in dog. Okay. Number 6 is A. Number 7 is C. Fatigue after exercise. Number 8 is B, as in boy. Patient with chronic ALS. Chronic. All the other things, there's some reason that you need to know what you're doing. newly diagnosed, respiratory distress, and a high quad, admitted. So he's recently admitted. Okay, number 9. That's a knowledge question. The answer is C. 10 is B, as in boy. 11 is C. 12 is D, as in boy. Yep. Upper motor neuron, the quad. 13 is B. 14 is C. Okay. We know that about the active. 15. Answer is C.
Oh, sorry.
Answer is C. Yes. Okay. Respiratory. 16 is A. 17 is B. Alternative power source. 18 is A. 19 is A. 20 is D. '21. The answer is D. Impaired verbal communication related to dysarthria. It's about speaking. Communication losses. 22. The answer is A. 23. The answer is D. 24. The answer is B, as in boy. No motor neuron. Number 25. The answer is C. Number 26. The answer is A. 27 is D. Number 28 is C. 29. The answer is C. That's what they're talking about. 30 is A. 31 is D. 32 is B. 33 is C. 34 is C. 35 is D. 36 is B, as in boy. 37 is B, as in boy. 38 is D. 39 is D. And because it's thin liquids. And 40 is A. That one I took, if you did the neurokaplan, it was on there. If you did the neurokaplan, that was one of the Kaplan questions. Okay, and the rationale and all that was there. 40, we're not even 41? 40? Oh, no, 40.
40 is
40. Let's do 40. If you got it, you know exactly why you got it. And it's an easy question. But if you missed the point, you missed the point. The answer is A. Airway. Dysphagia. I don't know how many times I could have said that in different ways. The answer is A. 41 is A. 42 is C. 43 is B. 44 is B. Okay. Pretty much everybody got 45. 2, 1, 3, 4. Right? 2, 1, 3, 4. Now 46, I tried to be generous. A, it's asked for the identify and define. It didn't ask for examples. If you gave me those two, that's fine, but you had to define it. So what's the definition of primary prevention? What you do so you don't get sick or you don't get injured. Which means risk factor identification and modifying the modifiable risk factors. B is the magic words there are screening and early detection. Screening and early detection. Nothing else really works. And tertiary prevention, what are you preventing? Complications of the disease or disorder. Okay? 47. 47 is really 2 and 3. I think I might have even crossed off tinnitus for a couple people, but that doesn't make sense. That's not an emergency thing. Number 48 is really everything. It's really all of them. Just because it says select all apply doesn't mean you don't select them all. Those are all possible with a new Guillain-Barré. And you definitely are concerned about dyspnea, diminished breath sounds, that sort of thing. So if you put them all, that's great. Now number 49, the answer is 2, 3, and 5. I hope you don't do number 1. That's going to make their hypotension and their orthostatic hypotension worse, and they'll lose their blood pressure completely. also doesn't make any sense to do 4. But you do apply 10 stockings and abdominal binder because when they sit up, you don't want their blood to go to their feet. Okay, and number 50, strange question, but the answer is 10 milliliters because it's for 24 hours. Okay? So,
I'm thinking
I
about
can't tell you everyone in this class passed. So if you got a 46, you're happy. If you got a 38, you're not so happy. But either way, you passed. Okay?
Oh, 48. Can you 48?
She said it's everything.
Not exactly sure because we didn't get all the reports we usually get.
Oh, okay.
Because they've gone to these freaking stupid things here. We got to run through the benchmark scanner, which aren't working properly. So this is the best we could do for this test. Hopefully we'll have nice fancy reports. You'll see on your report the class mean and all that sort of thing. It's usually around a 40. I need my test back and the paper clip.
I put it on.
Oh,
Oh, I didn't put mine on there.
it's Jessica. Okay, clip it back on there. Thank you very much. And I'll see you guys, some of you in lab, or tomorrow in lab. Everybody, be safe and be careful out there. You had yesterday to study, right? And shovel snow and take care of your kids who were off.
Yeah.
Which makes it a little less.
Not for me, I was snowed in at work.
You were, oh, and people that were snowed in at work. You got to go.